Good afternoon. My name is Jeff Kwong, and I'm the Interim Director of the Center for Vaccine Preventable Diseases at the Dalhousie School of Public Health. I'm very pleased to welcome you to our webinar on COVID-19 vaccine effectiveness. Today's panel discussion takes place during the World Health Organization's World Immunization Week, Pan American Health Organization's Vaccination Week in the Americas, and Canada's National Immunization Awareness Week. It is the first of two webinars that the Center for Vaccine Preventable Diseases is hosting during World Immunization Week. Join us for a webinar on ensuring global access to COVID-19 vaccines on Thursday, April 19th at 1 to 2 p.m. Eastern Time. This second webinar is co-hosted with the Institute for Pandemics, Dalhousie School of Public Health, and UNICEF Canada. The link will be shared in the chat. So before we start today's webinar, I would like to acknowledge the traditional territories of the Mississauga of the New Credit First Nation, Anishinaabe, Wendat, Huron, and Haudenosaunee Indigenous peoples on which the Dalhousie School of Public Health now stands. The territory was the subject of the Dish with One Spoon Wampum Belt Covenant, an agreement between the Iroquois Confederacy and Confederacy of the Ojibwe and allied nations to peaceably share and care for the resources around the Great Lakes. We would also like to pay our respects to all our ancestors and to our present elders. So just a few housekeeping items. We will try to address as many questions as possible. Direct any questions you like answered by the panelists to the Q&A function. And you could also direct any questions you have after the webinar to this email address, cvpd.dlsph@utoronto.ca. So I just want to let you all know that there's closed captioning in English available during the webinar, and instructions on how to view closed captions will be listed in the chat. Please keep in mind that this is an automated service, and we apologize for any errors made in the captions. So now, I'd like to introduce our panelists. We're very lucky today to have first Dr. Nicole Basta, who is an associate professor in the Department of Epidemiology, Biostatistics, and Occupational Health in the Faculty of Medicine and Health Sciences at McGill University in Montreal, Quebec. She is an infectious disease epidemiologist and vaccinologist with expertise in designing and implementing epidemiological studies that generate critical biological, clinical, and behavioral evidence to optimize the design and implementation of vaccination programs with a focus on influenza, meningococcal, HPV, measles, and most recently, COVID-19 vaccines. Our second speaker is Dr. Melissa Andrew, who's a professor of medicine and a consultant in geriatric medicine at Dalhousie University in Halifax, Nova Scotia. Dr. Andrew is an associate member of the Canadian Centre for Vaccinology. As part of the Canadian Immunization Research Network, she is co-principal investigator of the Serious Outcomes Surveillance Network, or SOS, where she studies how frailty impacts both vaccine effectiveness and clinical outcomes of influenza and pneumococcal infections in older people. And last, I'm going to be the third speaker. I'm a professor in the Department of Family and Community Medicine and Dalhousie School of Public Health at the University of Toronto. I'm a senior scientist at the Institute for Clinical at ICES and at Public Health Ontario. I am also a family physician at the Toronto Western Family Health Team, and I'm a researcher with the Canadian Immunization Research Network, a provincial collaborative network. So my research interests include infectious diseases epidemiology and health services research using linkable data, influenza and a vaccine and vaccination program evaluation, and assessing the burden of infectious diseases. So without further delay, I'd like to invite Dr. Basta, Nicole, to present her slides, to share her slides, and off we go.
Excellent. Thank you so much, Jeff. It's really a pleasure to be here today, and it's wonderful to join you and Melissa for this webinar. I'm going to start us off by talking a little bit about evaluating COVID-19 vaccine effectiveness, and particularly focusing on the what, why, and how. So what are we trying to evaluate when we look at vaccine effectiveness? Why is this important, and how can we go about doing this? So as many of you will be familiar, this past year in terms of COVID-19 vaccine development has been quite a whirlwind. In less than a year, we went from the sequencing of the SARS-CoV-2 virus to the first COVID-19 vaccines being authorized for use in Canada and elsewhere. And now in April 2021, more than 12 million doses have been administered in Canada. My group has been tracking COVID-19 vaccine development at covid19.trackvaccines.org. And currently there are 14 approved vaccines that are approved in more than one country somewhere around the world. And there are 110 COVID-19 vaccine candidates that are being evaluated in 312 clinical trials. In many, many different countries. This has really given us quite a wealth of information about the efficacy of COVID-19 vaccines, and it's really set the stage quite well for us to then begin to investigate the effectiveness of these vaccines. So how have we been able to make this progress so quickly? Well, there was a really nice paper about developing COVID-19 vaccines at pandemic speed that came out in 2020. And it looked at some of the elements that facilitated this rapid development, the significant financial investments, the global efforts, and the accelerated timelines. And these accelerated timelines took the traditional timeline of vaccine development, where each of the phases of vaccine development would proceed sequentially, and really overlapped them so that we were able to achieve phase 3 trial results and have those vaccine efficacy estimates even before some of the large scale manufacturing and scale up, so that as soon as vaccines were approved, they were ready to be distributed. And with those phase 3 vaccine trials, we got these really nice, robust estimates of the vaccine efficacy, how well the vaccine protected in the context of a clinical trial against specific outcomes, things like symptomatic disease, hospitalizations, and severe disease, depending upon the study. And these are just some examples of the vaccines that are authorized for use in Canada, what the efficacy estimates had that we obtained from those phase 3 trials. But these phase 3 vaccine efficacy estimates are really just the first picture of how well the vaccines are working. And we really need to go beyond these phase 3 studies in order to evaluate vaccine effectiveness as well. So I would argue that this figure from the paper has really missing a critical element, and that is the phase 4 vaccine studies that give us the opportunity to evaluate the effectiveness of vaccines in the real world. So at this juncture, now that we have many different vaccine candidates that are authorized for use, we need to turn our attention to evaluating vaccines at pandemic speed, because this kind of real-time evaluation of vaccine effectiveness will allow us to understand how well the vaccines are working under real-world conditions, and also how well our vaccination programs are working. So why are these phase 4 vaccine studies important? Well, first, they give us an estimate of the effectiveness of vaccines and vaccination programs, and they give us an opportunity to monitor the safety. So these phase 4 studies take place after vaccines are available and licensed or approved for use, and they are mostly population-based studies. So the approach is to use standardized protocols and validated study designs based on standard epidemiological and biostatistic methods to conduct these population-based studies once vaccines are widely being used in the population. And the advantage of phase 4 studies is that we can go beyond the constraints of the phase 3 clinical trials. Phase 4 studies can be conducted in many diverse epidemiological settings and many different populations, even among populations that were perhaps excluded from the phase 3 trials. And these can be done simultaneously in many different settings, which really gives us quite a wealth of evidence to draw upon. The benefits of phase 4 studies are that they provide that robust data that we need to go beyond the phase 3 trial results, but they complement the vaccine efficacy estimates that we saw under those ideal conditions of the phase 3 trials. These phase 4 studies are really critical because they can provide evidence needed to inform the rollout of vaccination programs and the design of vaccination programs. They can help answer questions like, what is the optimal timing between the doses of a vaccination schedule? And they allow us also to get evidence that we need to adapt vaccination programs as time goes on to ensure their success. So what can we learn about the effectiveness of vaccines from phase 4 studies? There's a whole host of different questions that can be answered using different phase 4 study designs and different methods. I'm just going to highlight a few of them here. So some of the key questions that we want to ask when we're conducting phase 4 studies of vaccine effectiveness is to estimate the population level effectiveness of the vaccines, to assess the duration of protection, and assess the breadth of protection. And these research questions are really critical. They complement what we've investigated in the phase 3 trials, where we've begun to investigate these issues, but they allow us to ask these questions in different settings, primarily under the real world conditions under which vaccines are being used, under a diversity of populations, in many subgroups that maybe weren't even included in the phase 3 trials. They allow us to ask how well these vaccines protect and how broadly and how long they protect against multiple variants, for instance, or against different endpoints that might be important as time goes on and we're trying to balance trade-offs in terms of the risks and benefits of vaccines. So these are the three key questions that are typically investigated in phase 4 studies, really trying to get a handle on the breadth and duration of protection and how well the vaccines work under real-world conditions. In addition, phase 4 studies can help us learn more about the effectiveness of vaccination programs themselves. So in these studies, we are interested in learning more about the vaccine effectiveness against different endpoints like infection or infectiousness. How well does a vaccine protect against infection or infectiousness? That lets us estimate some of the population level indirect effects of the vaccine. How well can the vaccination program itself drive down transmission so that we can see these beneficial indirect effects and try to achieve herd immunity. Phase 4 studies also let us evaluate different aspects of vaccination programs that we weren't able to evaluate in phase 3 studies. For instance, altering the dosing schedule or looking at different combinations of vaccines used in different groups at different time points that maybe have different levels of efficacy against different outcomes that might be most beneficial in different groups that are experiencing more severe disease, for instance. This also gives us an opportunity to evaluate how the level of vaccination coverage and the heterogeneity in vaccination coverage across the population impacts the reduction in cases and hospitalizations and deaths that we see in the population. So phase 4 studies, since they're population-based, they really give us that opportunity to not just look at the efficacy of the vaccine, which is something that's investigated when we see these individually randomized phase 3 trials, but they also gives us the opportunity to evaluate the program, the vaccination program itself, and understand how well it's working in case it needs to be adapted. So in terms of the study designs that can be used to evaluate the effectiveness of vaccines and vaccination programs, there's a huge range of study designs. Many of these are tried and true methods that have been used for many, many years to approach other vaccines, primarily influenza vaccine, but many others as well. And these include standard studies like cohort studies, cross-sectional studies or longitudinal studies, case control designs, test negative designs, household-based transmission studies, or those studies where you can look at the secondary attack rates of the infection within the setting of a household where some individuals may be vaccinated and some may not be. Stepped wedge or cluster randomized studies also are population-based randomized phase 4 studies that let you evaluate how well the vaccination program impacts transmission. And then there are a variety of natural experiments or regression discontinuity designs and interrupted time series that can be used to evaluate different vaccination policies. And these are really important as well because, as you'll know, many different countries and jurisdictions and localities around the world are implementing many different vaccination policies with different priority groups and difference of who is eligible when. So there are many vaccine effectiveness studies ongoing. Many have already reported results, but we actually need to continue this effort and investigate vaccine effectiveness from a lot of different perspectives. It's the combination of this evidence that will really help us understand how best to utilize COVID-19 vaccines. So I just wanted to highlight an example of a couple of different studies that are going on. So first, there's been quite a bit of evidence coming out of Israel evaluating the effectiveness of Pfizer vaccine. They've used, in this study that I'm reporting here, they've used a case control design to try to evaluate the real world effectiveness of the vaccine in their vaccination program, since they were able to scale up vaccination quite quickly across their population. It's a very interesting study and gave us some of the first real world evidence about the effectiveness of COVID-19 vaccines. A study in Brazil is using a stepped wedge design where the vaccination of the Sinovac vaccine is being evaluated to understand how well it prevents transmission. In this design, an entire town will be vaccinated, but in a stepped wedge approach, meaning that a certain proportion of individuals will be vaccinated first and then followed, while the others remain unvaccinated and are followed over time. Then sequentially, each area of the town will be vaccinated, or each group within the town will be vaccinated until everyone is vaccinated. And throughout that time period, outcomes will be evaluated to determine how well vaccination can impact transmission. It's a really interesting design and definitely one to watch. And then a study ongoing in the US using Moderna vaccine is going to be looking at how well that vaccine can prevent transmission among US college students. So it's a multi-center study among many US college students, and it's going to try to help us understand, now that we know the efficacy of these vaccines from the phase 3 trials, how well do they actually control and prevent transmission in the population? A really key question going forward. So these types of vaccine effectiveness studies are really critical. At this point, we have used more than 1 billion COVID-19 vaccine doses administered in more than 170 countries. And many of these programs are very different from one another in terms of who's eligible, how the vaccine is being used, the timing of the doses, and these types of aspects. So evaluating the effectiveness of these vaccination programs under these conditions, under different epidemiological settings, in different age groups, in different population groups, is going to be really critical. And there are many opportunities here in Canada to do these types of studies as well. And you're going to hear about that today from my fellow panelists. So I'll just wrap up this section by talking about how critical it is to ensure that we advance our understanding of how to optimize the use of COVID-19 vaccines, and how important vaccine effectiveness studies are to that aim. They really provide the evidence we need to inform vaccination programs and policies going forward, because vaccination policies need to adapt as the epidemiology of the disease adapts and changes. And the more evidence we can gather from vaccine effectiveness studies, the better position we'll be in to control COVID-19 going forward. So with that, I'll thank my group who runs our COVID-19 vaccine tracker, and thank you for your attention.
Great, thanks so much, Nicole. Okay, moving on to Melissa. Are you able to put up your slides, please?
Great. Thanks for the invitation to be here today. I'm joining you from Halifax, which is in Mi'kmaq, the traditional unceded territory of the Mi'kmaq people. So I'll be talking to you about vaccine effectiveness in a specific setting, which is looking at inpatient hospitalizations. So these studies are funded by the Public Health Agency and CIHR mainly, and my own disclosures are there as well. I have other grants for different projects. So thank you so much, Nicole, for starting things off with that great framing talk. So I'll pick up on a couple points and then talk about our specific way of looking at vaccine effectiveness. One reason that this field can be confusing is that we use the term VE to mean two different things, and really many different things within that. So vaccine efficacy is the results of randomized trials, which you would have seen reported in the earlier days, especially when the big companies were releasing their results. And those are maybe harder to generalize to the real world because of the way that those studies are conducted with restricted inclusion criteria and age criteria, and also just the setting and the sample of where they're being conducted. Like, are there variants circulating? Is there a lot of community transmission or not? So that's why those estimates even can vary amongst themselves. But what we're talking about here today is the vaccine effectiveness, which is really translating to the real world. And an important thing to think about is you'll get different estimates of vaccine effectiveness when you look at different settings or different outcomes. So what I'll be talking about is vaccine effectiveness in the protection against severe outcomes like hospitalization and ICU admission and mortality. And as Nicole mentioned, in many ways, the vaccine effectiveness studies can be more clinically relevant as long as they're done in a robust way. So our serious outcomes surveillance network has been running for about a decade. It started around the time of the H1N1 pandemic, actually. So it's been designed for pandemic response, and we were able to pivot quite quickly to COVID-19. Currently, we have 4 provinces participating in inpatient surveillance for COVID-19, and the sites are listed here. So we do active surveillance, which is another key feature. We want to make sure we catch all of the COVID related admissions to the Sentinel hospitals. The cases are all confirmed using PCR testing. And for calculating vaccine effectiveness, we need to match the cases with controls. And you'll see how that works in a minute. We are able to collect detailed clinical and demographic characteristics on our enrolled patients. And we look at these more serious outcomes. So just a little primer on how we can calculate vaccine effectiveness. We use this test negative case control design. So you have essentially, this is the equation, but I'll show it in infographic here. So we have a group of people who are admitted to the Sentinel hospitals with COVID-19. Those are shown in the blue. And then we have matched controls who had a similar presentation with a respiratory illness or infection of some sort, but didn't have COVID, and they're shown in the green. So then we look to see how many of each group were vaccinated. And then we're able to do this calculation that's based on the odds ratio of the vaccinated people versus the unvaccinated within each of the groups. So in this case, we might get a vaccine effectiveness around 89 or 90%. And we're able to adjust for key covariates such as age and frailty, which is an important thing because it makes a big difference. So just a couple of early results from our network in case you're curious. So this is the epidemic curve of our admissions to date, showing how many patients have been enrolled to the network, and it's color coded by province. So you'll probably be all interested in seeing where your provinces sit. And you can see the waves quite clearly there. So one of the key things, as I mentioned, and it's why I'm involved in this as a geriatrician, is that we consider the clinical characteristics of our enrolled patients. So one way we do that is with their frailty. And so here's one way of measuring frailty on a scale of very fit to very frail. And so we collect that data, and this is a summary. So for the admissions during 2020, we had about 2/3 of people being over 65 and about 1/3 being under. And as you would expect, the people over 65, which is seen on the right, is a more frail group. So there's more people who are more highly frail. However, really, even among the younger individuals, we do have some quite frail people, which is important, and it really shows the reason that adjusting for age alone isn't sufficient. So now, because we have not yet done vaccine effectiveness estimates in COVID, I couldn't show you any of those, but we do have lots of previous data from our influenza work, and this is just one example. So here we see a season in which we were able to do detailed adjustment for frailty, and we saw that the unadjusted vaccine effectiveness estimates for people over 65 was about 45%, whereas it went up to 58% once we adjusted for everything, including frailty. And really a key point from that season, or that paper that we published, was that adjusting for frailty is the most important thing to consider. So that's why it's quite critical in our work on COVID as well. We can then use our clinical data to stratify. We could stratify vaccine effectiveness by sex, by age group, or by frailty group. The frailty group is seen here. So what we see is that vaccine effectiveness tends to be quite high among people who are not frail, even if they are older, but it decreases with frailty. Of course, the frailest people are the most vulnerable, and we need to be most concerned about protecting them. And that's why it'll be interesting to see how the COVID vaccines perform, because they do seem to be more effective for older people than some of the older types of vaccines in other conditions. Here's another example where we do have this story that vaccine effectiveness is always lower in older people, but we've found that that's not even always the case for influenza. So here, for example, on the left are 3 estimates of vaccine effectiveness in around 40 to 50% for adults. But in fact, when we look at that's just against hospitalization. But when we look at other outcomes, such as protecting against ICU admission or against mortality, vaccine effectiveness may be higher. So really, vaccine effectiveness varies according to the outcome you're looking at, according to the strain. Perhaps here the variants we'll be looking to with COVID. So there's always an evolving story. So here are some key points about vaccine effectiveness in the hospital surveillance. Really, it's important that we do active surveillance, looking for cases rather than relying on reports from lab data. We use this test negative case control match design, and we're able to adjust for important confounders and clinical features. We estimate protection against serious outcomes rather than some studies look at protection against lab confirmed illness in people who don't require hospitalization. So that would be a different estimate again. And really what we can do therefore is part of the vaccine effectiveness puzzle. So here are our funders and partners, and thank you for your interest. Happy to take questions later.
Great, thanks so much, Melissa. So let me share my slides now. Here we are. Okay, great. So I'm just going to turn off the chat in the Q&A. And great. Okay, so I'm going to talk about some of the activities that the PCN network of CIRN is doing. Okay, so first of all, I have no financial conflicts of interest to disclose. So, so the Canadian Immunization Research Network, or CIRN, was created in 2015, and the PCN, or Provincial Collaborative Network, conducts public health relevant vaccine research and evaluation using provincial databases. And so, we've obtained a funding from CIHR and the COVID-19 Immunity Task Force to conduct post-market studies of COVID-19 vaccines. So we're going to be looking at coverage, safety, and effectiveness. For today, I'm only going to be talking about effectiveness. So these are some of our partners that I've listed below, and I'll show you again on the next slide. So we've got, for this effort, we've got 5 participating provinces so far. So Ontario, Quebec, BC, Alberta, and Manitoba. And you can see the populations here totaling about 34 million, which is about 90% of the Canadian population. And these are the institutions involved. Okay, so this is just a schematic of the data holdings that we have at ICES. So ICES is a nonprofit research institute based in Toronto, but also with satellites across Ontario. And we house all the health administrative data in the province, as well as a number of other health-related data sets. And so this is just to show how all our data sets get linked up. We have a data set called the Registered Persons Database, or the RPDB, which is basically anyone who's ever had a health card in Ontario. And we have something called an ICES key number, or IKN, which is basically an encrypted version of the health card number that we can link to all of these health administrative databases. So every time somebody sees a doctor, the doctor will submit a billing claim for providing a service. Or if you submit a claim for your medications, it's in this Ontario Drug Benefit Claims database. And if you go to an emergency department, or if you're hospitalized, all of these interactions with the healthcare system are captured, and they can be linked so that we can monitor, like, people, who see a physician, go to the emergency department, get hospitalized, and on certain medications. And we can also use algorithms to apply them to the health administrative data to identify people with certain chronic conditions. So for instance, we can say that if someone had a visit, a hospitalization coded as diabetes, or 2 physician visits coded as diabetes, then they probably have diabetes. And so we can identify people with certain comorbidities using these databases. And then we can link all sorts of other databases together that we bring in for specific studies. And so I'm going to be talking about those in the next slide. So basically, this sort of infrastructure is available in Ontario, and as well as similar infrastructures are available in the other participating provinces. So what we have for our data infrastructure for our COVID-19 vaccine efforts are that we need the COVID-19 vaccination data. We need COVID-19 laboratory testing data. And so these would be based on PCR tests. And then we also have data on outcomes. So outcomes like mortality, hospitalizations, including ICU admissions, emergency department visits, and then also physician office visits are all going to be captured. We can also look at a number of different populations of interest. So whether it's long-term care residents, different age groups, whether older adults or children, we can look at them. Those with chronic conditions. So there's a whole list of chronic conditions that I won't go into that we can capture using the administrative data. We can also capture pregnant women. We can look at immigrants and refugees, at least in Ontario. And then also indigenous populations using some other data sets. And then homeless population, at least a subset, the homeless population who have had interaction with the healthcare system. We can look at different geographic regions, whether at the public health unit or smaller levels, like based on your postal code or the first 3 digits of the postal code, also known as the forward sortation area. And then we can look at individuals who are at increased risk of COVID using the area level measures available in the census. So we can look at areas where there's more essential workers, like people who can't work from home, areas where there's larger household sizes, lower income or education, more visible minorities, and more recent immigrants. So I've already, Melissa's already talked about the test negative design, so I'm going to skip over this slide. And then, so what we've done, I'm just going to present some of the preliminary results that we were working on recently. And this is an ongoing effort. So we're like literally doing some more analyses like, every day. So this is data from those who are tested for COVID between December 14th, which is when the program started in Ontario, and then March 11th. And they had to be symptomatic at the time of testing. So that's a key component. They have to not only present for testing, but they had to be symptomatic. So we had records on a subset of those who were tested where symptom information was recorded. So we excluded the long-term care residents because that's kind of like a different population. And then we also excluded those who had a previous COVID infection. And then we ascertained their vaccination status from another database called COVAX-ON, where we looked at the number of doses received and the time from their most recent vaccination to the date of test. So in this analysis, we had a little bit more than 200,000 symptomatic individuals who were tested for the coronavirus, of whom about 27,000 tested positive, or 13.5%. And also there were, in this 200-something thousand, there were about 3% or close to 6,000 who had received at least 1 dose of an mRNA vaccine. So if we've grouped them together, the Pfizer, it was 84% had received Pfizer and about 16% had received Moderna vaccine. And the majority for each had received only 1 dose by the time that they had been tested for COVID. So here are just some preliminary, like I said, estimates of vaccine effectiveness at these different intervals. So, among those who had only received 1 dose, so you could say that they are partially vaccinated, from 14 to 21 days, we had an unadjusted VE of 71, and then after adjustment, we had a VE of 60%. And then you can see at 21 to 27 days, it went to 65, and then 28 days or more, it went to 67. And we adjusted for sex, public health unit, region, and then bi-weekly period of tests, number of tests in the 3 months prior to the start of the program. So this is kind of a measure of like healthcare workers and other people who are at high risk for having multiple tests. And then we also considered area level measure of visible minorities. And then after 2 doses, so this is at least 7 days after the second dose, we had a high VE of 95%. And how did these estimates compare with other places? So this is the data from Israel that was published in New England Journal of Medicine. I think there was an early release in February. And so our estimates are pretty similar to theirs. And their estimates in turn were very similar to the phase 3 trials. Okay. And then here it is by product. We looked at the Pfizer separately from the Moderna, but we looked at just, after 14 days after dose 1 and after 7 days after dose 2. And you can see that the estimates are very similar between the 2 products, and that's why we grouped them together. And we're doing a whole bunch of other analyses, looking at it by age group, by timing, like, different periods. And then we're also going to be looking at VOCs. So we've last week added more recent data, so up to April 19th. We're going to be looking at longer intervals after the first dose. We're looking at vaccine effectiveness against AstraZeneca vaccine. And then looking at severe outcomes, so hospitalizations or death. We're going to be looking at VOCs. That's something that these are things that we're working on like this week. And we're also going to be looking at the VE in the long-term care population. So we'll be doing that separately from the non-long-term care population. And then lastly, we're going to be using other study designs as well. So we're going to be checking out cohort designs just to confirm that our test negative design estimates are valid. Okay, so I just wanted to acknowledge the PCN study team. So what I presented is just what's happening in Ontario. There are parallel analyses happening in these other provinces, or at least Quebec, Alberta, Manitoba, and BC. We also have some investigators from Nova Scotia. Unfortunately, we don't have access to the data in Nova Scotia yet, but they're working on that. So hopefully, once we generate the estimates in each of the provinces, we will use meta-analytical methods to to combine the estimates from the different provinces as well. Okay, so I'm happy to answer any questions about this, and we'll also be taking questions from directed to all three panelists. So I'm just going to end the show and then start looking at the questions. So I know there are a lot of questions that have come in, and so I think we'll just get right to them. I think there's a lot of overlap. We had some questions that were prepared previously in advance, but I think there's a lot of overlap between the questions. So I think the first question is speaking to, let's just see here. So yeah, so I think the first question we'll ask is, I think what people most want to know about is if we have evidence about this, delaying the second dose, and what is the evidence for delaying the second dose, and should they be concerned about that? So I don't know if anyone wants to address that question first.
Yeah, I could start off,
Sure.
Jeff, and then maybe you and Melissa could add something if you like. So the key issue with whether or not we have the optimal timing of doses for vaccinations is remembering that there are kind of two levels of effectiveness that we're interested in. How effective the vaccine is for the individual in terms of reducing their risk of disease, and what population level effectiveness we can achieve over a short period of time to drive down transmission for everyone. So with phase 3 individually randomized trials, we only get an estimate of the vaccine efficacy on the vaccination schedule that was investigated. And typically a very limited number of vaccination schedules are investigated, or usually only one schedule. So whenever we're then taking the evidence from a phase 3 trial and trying to translate it into a vaccination program, we have to figure out not only what is the optimal way to prevent disease for the individual, but how can we most quickly drive down infection in the entire population? And that was sort of the reasoning behind the lengthening of the timing between dose 1 and dose 2 for the COVID-19 vaccines in Canada. The idea being that if we could get a larger proportion of people to have some efficacy from the first dose of the vaccine, even if that may wane between the first and second dose, but we don't have evidence about whether or not that will happen or how quickly that will happen, that may actually prevent more cases than vaccinating a smaller number of people on the schedule that was seen in the phase 3 study. So that's kind of the big picture behind the debates about the timing of the doses. Vaccine effectiveness studies that we're talking about today are the perfect types of studies to evaluate how effective different dosing schedules are outside of clinical trials. So clinical trial gives us really limited evidence about which dosing schedule to use. And it's when the vaccines are being used in different schedules in the population that we can use designs like you and Jeff and Melissa were talking about to evaluate how effective those have been overall in terms of driving down cases, hospitalizations, deaths, and transmission. So it's kind of a general answer to that question. But that's kind of how I think about it, that it's really important to think about not only the maximizing efficacy for the individual in terms of the schedule of vaccines that are given to an individual, but the population level efficacy and how quickly we're scaling up to a population level effectiveness, and how quickly we're scaling up to a high proportion of people having some reduction in their risk of disease.
Thanks, Nicole. That was a fantastic response. Melissa, do you want to add to that?
Yeah, I think that was a great way to put it. And really just to say that this is exactly why we're doing these studies. I mean, this is one of many questions. Another thing that will be interesting to know is how well a single dose protects against the severe outcomes, hospitalization, ICU admission, rather than perhaps a milder infection. And so this is, really stay tuned for this evolving evidence.
Yeah. And I'll just add that, the data that I presented was just against, I just want to emphasize that that's just against symptomatic infection. And so, possibly just the milder forms of illness and not necessarily hospitalization and death. And we may see higher VE estimates for the more severe outcomes. So that's something that, our group is working on as well. And so I think the thing to keep in mind is you may have seen lower VE estimates after just the one dose. And we all know that. But the question is, is it better off protecting double the number of people, having double the number of people getting at least some protection rather than half the number of people getting just only, slightly higher amount of protection. And this is something that's definitely we need to monitor, with all the studies that are going on. Okay, so I think that's, I think there's definitely a lot of uncertainty around this, but I think people have made the decisions based on the best available evidence, the information that we have available at this time. And, it's a dynamic situation, things may change, but I think for this time, given the limited supply that we have, I think it was the best decision to go with the first doses fast strategy, at least in Canada. Okay, so moving on to the next question, there's a question from Thomas about, effectiveness of vaccines against the various variants out there. And if we could comment on that. And so maybe I'll just give a start. I mean, this is something that we're definitely on our radar and that it's something that we're working on. I will say that in Ontario, we've been seeing a lot of variants already. It's so it's starting in December, it's been till presently, it's been rising steadily. So even as of I think by March, it was at 50% where the B117 variant that originated was originally found in the UK, and now it's up to 90%. And so that's one of the things that we're going to be working on. I don't know if Melissa or Nicole, you have anything to add to, if you're aware of any data from other jurisdictions. I think some of the studies that were done in Israel and the UK, they did have the UK variant present there. So their estimates do account for the presence of those variants already.
Exactly. And that's one of the reasons why it's really important to reflect on these settings where these different studies are done, both the clinical trials for the vaccine efficacy, but also the real world phase 4 vaccine effectiveness studies. Because if they're done in a setting with a high circulation of a variant, that may make a comparison to another setting that has maybe a different variant or no variant yet, quite just different. So there's a lot of heterogeneity there. So it's something to keep in mind for sure. But our network is part of a global hospital surveillance network that has sites at many countries around the world. And what we've been hearing, even just informally from our colleagues at different sites, is that once a variant takes hold, it really becomes the dominant circulating COVID in the area fairly quickly. And so one of the things that's important is to do sequencing to really understand the movement of these variants. That's something that we'll aim to do as well.
Mm-hmm. Now
Yeah,
there's,
and I would,
oh, go ahead,
sorry.
Nicole. Go ahead.
Oh,
Yeah.
thank you, Jeff. I was just going to add that to that. I hear a lot of concern about whether the vaccines will be as effective against the variants, and rightfully so. We really do need to investigate this question, especially as we're seeing the spread, a broader spread of more variants. But I want everyone to keep in mind that we're using vaccines in combination with a lot of other public health measures. So even if some of the vaccines are less effective against certain variants, because we're using them as a package of public health control measures, they can still be effective overall. So I caution people from getting too concerned if they see lower estimates of efficacy against certain variants with the vaccines, given that we have other tools to prevent the spread of variants as well, including using masks, including social distancing and other factors to reduce density. So keep in mind that we're not relying on vaccines as their only method to prevent against the spread of variants. They need to be used in combination with a number of other public health measures as well.
Great, thank you. So another question, and Nicole, you flagged that you want to answer this question from Zoe. And so the question is the probability that vaccines currently in phase 3 trials will complete the trials and make it to market, given the large number of vaccines already approved. So the Medicago plant-based VLP vaccine is currently recruiting participants in Toronto, but how can you run a trial with a placebo arm during the current wave 3 when other approved vaccine candidates are available?
Yeah, this is a great question. There are dozens of vaccine candidates that are still in phase 3 and even ones that are in phase 2 and phase 1. As we can see from the great global inequity of vaccine doses being used now, we need more vaccine candidates to become approved and more vaccine doses to be manufactured. So I think there is going to be a continued effort to move those vaccine candidates through the pipeline from phase 1 to phase 2 and phase 3. In terms of testing vaccines in a phase 3 trial, when other vaccines are approved, that's where the design of some of those studies are likely going to need to change. A lot of the phase 3 studies right now are placebo-controlled trials where individuals in the placebo arm aren't vaccinated, but they could be studies where the candidate vaccine is tested against an already approved vaccine in the comparison arm. Or it could be a design where there's delayed vaccination. So everyone in the trial gets vaccinated. Some people get vaccinated immediately when they enter the trial. Others get vaccinated maybe 2 months later. A number of these studies that are taking place in places where not everyone does have access to the vaccines yet, either because vaccination rollout hasn't started or because the age group that they're being tested in, the vaccine is not yet available for. So given that we have this limited vaccination supply globally, a lot of those phase 3 studies will still be able to produce the results that they need. And some of the others may need to adapt their design to not use a control group any longer, because we certainly wouldn't want to withhold vaccination from anyone during a global pandemic.
Yeah. Okay. Now here's a question about getting the first dose of Pfizer and then getting Moderna as a second dose. And I know that there are clinical trials in the UK that are happening that are looking at this. I think we just have to wait for that. I don't know if either of you have any response to that. We just don't know.
Only to say that this is another area where vaccine effectiveness studies are really, really critical. We can't learn everything that we would want to know. We can't gain all the evidence we need to design our vaccination programs from phase 3 trials, because you just can't test every different combination of schedules and doses and candidates and these mix and match approaches. So this is where a lot of the effectiveness studies that are taking place will give us more evidence.
Yeah. So a question from Samar is that, are there any studies outside of Canada looking at vaccine effectiveness, comparing the recommended mRNA, vaccine dose interval versus the current model of the delaying the second dose? And I would say that in the UK, they have used the strategy. And so I think that would be one jurisdiction to look at, that they'll be more likely to have data. So there was data from England and then also from Scotland, actually just last week, that came out. They are using a combination of AstraZeneca as well as Pfizer. So I think when you look at those studies, you have to take that into consideration, that they try to present the estimates for those different vaccines in particular. So, and then within Canada, there are some provinces that adopted the delaying the second dose strategy earlier. So they may have more data more quickly about looking at like longer term VE estimates for just after the first dose. Compared to Ontario, we're only switched over to that in early March. Okay, so a question from Peggy about how do people learn about updates on the research? Is there a website or upcoming webinars? That's something that I'll need to work out of how do we share this more broadly. I mean, some of the stuff, the reason I didn't present the more recent data up to April 19th today is I haven't even shared it with my co-investigators yet, like Nicole, so she hasn't even seen those results yet. So that's why I didn't feel as appropriate to share them here today during this webinar. And so I'm just trying to scan through these questions to find different questions here. Because there's a lot of questions about these, delaying the second dose. A question from Heather about whether there are differences in the prevalence of variants among those who with one dose of vaccine. And so I can tell you, Heather, that PHO, Public Health Ontario, is actually preparing a report looking at breakthrough infections. So people who have been vaccinated and were confirmed as being positive for COVID. And so I think you should look out for that report. Hopefully it will be coming out soon. And then I'm just, sorry, just keep going, scanning the questions here. Yeah. And there's a lot of questions about the variants. And I think that's something that we just don't have the data. And I think the problem is we have to wait for these things to happen. And then we need to wait for enough of them to happen before we can do these studies and report them. So there is going to be a bit of a delay, but hopefully in the coming weeks, we'll be able to share some more information. Like, I mean, everyone's working as quickly as they can on these analyses.
Yeah, and I think, Jeff, this is where genomic surveillance is so important so that we know which variants are circulating, which jurisdictions and which countries, and we really have a good sense of what proportion of breakthrough cases among vaccinated people are caused by certain variants, what proportion are not. I think that's really a critical element of public health surveillance in terms of vaccine effectiveness and monitoring the effectiveness of vaccines going forward. Yeah.
Another question about like, we're going to be doing analyses of longer intervals. Will these be done by age also? So I think my response to that is it's sometimes tricky. We're going to be looking at the VE estimates by age group, and we're going to look at it by intervals, but I'm not 100% sure we'll be able to look at it by intervals by age group, because once you start cutting the data too finely, then you will have your estimates become unstable. But I'll try to do that. That's, I think, a good suggestion that I will try to incorporate in the analyses that we're doing. Thanks for that suggestion from this anonymous attendee. Let's see, here's a good question. Are there study designs that make it possible to tease out the rates at which vaccinated individuals are asymptomatic carriers infecting their close contacts? Nicole, I think that would be like household transmission studies, wouldn't it?
Yeah, definitely. Household transmission studies would be a great design where you routinely monitor individuals to determine whether they're infected or not, even if they're not symptomatic. And then the study that I mentioned, the Prevent U COVID study, the college study among US college students, is going to be doing that as well. They're going to be routinely testing participants, some who have gotten vaccinated immediately, some who will get vaccinated 4 months later, and determining the rates of asymptomatic infections among those participants according to their vaccination status. And also they're enrolling a cohort of contacts of those students who are not being vaccinated in the trial, but that are in close contact in the dorms and in the college society. And they'll be testing them to see whether or not they're infected by those index individuals that are in the trial. So this will really be a great network to try and help us understand how the virus transmits among those who are vaccinated or not vaccinated, and how well the vaccine can prevent against that transmission.
That's a great point, and it also raises the richness of our toolbox when it comes to study designs. Because we've been working in this field of vaccine effectiveness for quite a long time on other pathogens, other viruses, we've got many different study designs that can then be applied to the COVID situation in a way more rapid way than they could be done if we had to invent them from scratch. So just like our vaccine development has benefited from the foundations of research that have been supported over the years. The study design and the research experience can really pivot very quickly as well.
Yeah. There's too many questions to go through all of them. So I'm just trying to, are there any studies looking at antibody levels or titer levels to see how this matches up with vaccine effectiveness? That's from Kate Allen. Anyone aware of that?
So
Melissa?
certainly that's part of what they do in vaccine efficacy studies, like the manufacturers would have done studies looking at the titers and the vaccine, immune responses. It is a very good question, and I think we're still on the search for what they call correlates of protection, meaning, what blood test or other tests can we rely on to say that someone's protected or not? And that's another area where the field of immunology is really still working on.
And once those correlates of protection are determined, I know there's a lot of analyses going on with the phase 3 trial data for the Pfizer vaccine, Moderna vaccine, all of the vaccines, to try to determine what are those levels of different elements of the immune response that predict whether or not you'll be protected by the vaccine. Once those factors are determined, then we can kind of expedite our evaluation of vaccines and not need to have efficacy endpoints, but we can just look at these immunogenicity endpoints. It will allow us to evaluate new vaccine candidates much, much more quickly and ask some of these different questions about the effectiveness in different populations in a more expedited way. So that's really something that we're all hoping that is determined as soon as possible.
Yeah. Okay. So there are so many questions here. I just trying to find some that are of the most broad interest. I mean, I think there are a few questions about data for children. I know there are trials underway. I'm not sure when the effectiveness studies will be done. I mean, the real world effectiveness studies will have to follow the trial data, and I haven't seen any trials data in children yet. I do know that some trials are underway already. Melissa,
Yeah.
do you have any comment about that?
Yeah, currently, I don't know of any place in the world where vaccines are approved for any individuals under age 16, but Pfizer did complete their trial in children 12 to 15 years old and applied for review from the FDA just recently and found really high efficacy among 12 to 15-year-olds. And I believe that the Pfizer and Moderna trials going down to children 6 months of age have already started as well, but they haven't reported their results yet. So there will be some evidence coming for individuals in those younger age groups. Yeah, there was a related question about booster doses for variants of concern, and several of the vaccine manufacturers are now testing booster doses that can hopefully protect more broadly against some of the variants of concern that have emerged since they completed their phase 3 trials as well. Great.
There's a question about, and this to me, noting that VE was more than 60% after 28 days, but how much longer, how much, is there much data for the 4-month stretch between dose 1 and dose 2? And so what I've seen from our latest cut is that even after 49 days, so 7 weeks, we still have good VE. So, I mean, I think we just have to wait and see. The problem is we won't know till there's enough people who've, had enough follow-up time to know if it will last 4 months. So kind of nobody really knows the answer to that. It was just kind of, some people say an educated guess, other people say calculated risk. I think it depends if you're like a half glass empty or half glass full sort of person. But I think it was based on, the amount of vaccine we had available and when we're going to be getting them. And I think, hopefully, between that and the public health measures, we'll be able to get control of this third wave in the coming weeks. So it is close to time. And I just want to remind everyone that if you didn't have your questions answered, you can send an email and we'll try our best to answer them. And we want to thank everyone, especially the panelists, for being here today. And there will be a link of the recording of this that will be posted on our website sometime in the future. And lastly, I just want to thank Liz Loftus and Shaza Fadel, who are in the background helping to run this webinar and organize this. And I want to thank all of you for attending today. So I just want to make sure I got those things in before we signed off, but it looks like we still have 2 minutes. I'm just going to scan through these questions. If there are any other, if Melissa or Nicole, you see any that you want to answer, please feel free to jump in and try to answer some of these. There's
Someone's asking the question about, I had said that they can be more, these vaccine effectiveness studies can be more clinically relevant, and to expand on that. And really it's just about if the efficacy studies are done with a very limited healthy volunteer population of a certain age group, not older people living in nursing homes, for example, then it might be difficult to apply the vaccine efficacy results from that trial to a nursing home population. Whereas when we look in the real world, we're able to apply it more readily, as long as we've done the sample design properly, and also the analysis, and taking account of the really important variables such as like frailty, age, socioeconomics, these sorts of things.
There's a question about whether antibody levels are being followed among Canadians with no second shot yet. Definitely, there are a number of groups that are looking at antibody levels. And I mean, the challenge is that we don't have what we call a correlate of protection. We don't exactly know, what is the level of antibodies needed for protection, but definitely there are groups that are monitoring levels of antibodies and like samples of the population of different Canadians. They're funded generally by the COVID-19 Immunity Task Force. Okay, so now it's 1 o'clock. So thank you very much. We're going to have to end the webinar now, and we look forward to having you join us for future webinars. Okay, take care, everybody. Bye now.